Today we'll be talking about hearing loss in newborns. Hearing loss affects between 1 and 2 of every 1,000 newborns. The inability to hear can delay the development of language, and that's why it's so important to detect early, because we can intervene either with hearing aids, speech therapy, or other interventions to make sure that these babies don't get behind in their development because of a hearing loss. We have here on the right a picture of a baby who has a couple of electrodes on their forehead and cheek, and they also have an in-ear microphone. So this baby is undergoing what's called ABR, or auditory brainstem response testing. And this is one of the 2 forms of screening for hearing loss in newborns. The other being otoacoustic emissions, which we see here. So again, these are the 2 main ways that currently most places around the world will test newborns for their hearing. We'll talk through some of the similarities and differences between these 2 techniques. Essentially, ABR testing, auditory brainstem responses, is measuring the electrical activity in the brain in response to a sound that microphone is making into the baby's ear. So usually there will be some type of electrical activity in the brain whenever a particular tone is played. If there's not, then that's concerning for hearing loss. And in contrast, otoacoustic emissions measures sound waves produced in the inner ear in response to a sound that is produced by a microphone. And so actually, whenever you hear something, your inner ear hair cells, which are the sensory cells of the inner ear, sort of reflect back a sound, a very faint sound that can be detected via this OAE technology. So kind of cool. There's also differences in terms of cost and setup and performance time. So ABR testing is in general more expensive because they use disposable electrodes. It's also a more time-consuming test to set up and perform. OAE testing, in contrast, is less expensive and quicker to set up. It doesn't require these electrodes that can be somewhat time-consuming to place. And the other major difference between ABR and OAE is that ABR can detect auditory neuropathy. Now, this is essentially hearing loss that's due to abnormalities of the auditory nerve, right? So the nerve that transmits signals from the inner ear to the brain. And OAE would not be able to detect auditory neuropathy because of the limitations in the technology that's used. So both of these techniques are non-invasive, so there's no pokes that are required, and they don't require any active participation from the newborn. We're just measuring biologic data from the newborn themselves. So the reason you perform this just prior to hospital discharge and not right at birth or shortly thereafter is to allow time for some of the fluid that might be present in baby's ears, because remember, baby's been sitting in amniotic fluid for many months. You want to give time for that fluid to clear out, because that can result in a false positive. You can think, based on your test, that the baby has hearing loss, when in fact all they have is fluid. Hearing loss can be classified in a few different ways, and I've listed a chart here as far as how we're going to cover it in this talk, but I want to break down first genetic versus environmental. So there are monogenic causes of hearing loss that are well established. You're seeing some of those here. GJB2 hearing loss being the most common monogenic form of non-syndromic hearing loss. And then we have environmental causes as well. Many infections can result in hearing loss, both in newborns as well as in older children. Sensorineural versus conductive is another way to group hearing loss, and we'll see kind of the difference between these two, because there's an anatomic relationship that I want to point out. But essentially, sensorineural has to do with the inner ear or the auditory nerve, and then conductive hearing loss has to do either with the outer ear or the middle ear. And as you can see, there's a couple of other ways to subclassify hearing loss. Those include syndromic versus non-syndromic. So are there symptoms other than hearing loss, or is it only the hearing loss? There's prelingual versus postlingual. So did the hearing loss start before or after the baby started to talk? And then there's progressive versus stable. So is the hearing loss getting worse over time, right? Or is it staying the same? About 80% of genetic cases of hearing loss are autosomal recessive in nature. GJB2 related hearing loss is the most common non-syndromic cause of congenital hearing loss. And syndromic hearing loss is also a good category to be aware of. As we mentioned, this involves one or more organ systems outside of the ear. Examples include Usher syndrome, which is related to vision loss as well as hearing loss, Pendred syndrome, which can present as a thyroid goiter in teenagers, and Jervell and Lang-Nielsen syndrome, which can present with cardiac arrhythmias and potentially sudden death, in addition to hearing loss. Now, there are important environmental causes of hearing loss to be aware of. The first one I want to point out are maternal infections. So these include CMV, Zika virus, and rubella. Birth trauma can also be a cause of hearing loss, as can hyperbilirubinemia and antibiotic exposure, in particular aminoglycosides. Now, sensorineural and conductive hearing loss can be understood anatomically. So, conductive hearing loss is due to pathology of the outer and middle ear, whereas sensorineural hearing loss is due to pathology of the inner ear, mainly the cochlea, as we see here. I just want to point out the outer ear consists of the pinna and then the ear canal, or the external auditory canal. These structures collect and transmit sound waves to the eardrum, and the eardrum is attached to the ossicles, which are the three small bones inside of the middle ear that help to transmit sound waves from the external auditory canal to the cochlea. Now, the cochlea is the sensory organ that translates the sound waves into electrochemical impulses that are transmitted via the auditory nerve, which we see here, onto the brain, which processes the sound and is what results in hearing. So it's good to know the anatomic correlation between these two different types of hearing loss, because they do have different treatments as well. Okay, so as we mentioned in the previous diagram, sensorineural hearing loss is due to a dysfunction of the cochlea or the auditory nerve. And then conductive hearing loss is due to an abnormality of the outer or middle ear. So that's what I mean here. And then we can see there's also in some cases mixed causes of hearing loss that are both sensorineural as well as conductive. Management of hearing loss is multifaceted and can include any of the following. So hearing aids, which help to amplify sound, cochlear implants, which stimulate the auditory nerve and which require a surgery to implant. Other types of surgery to repair the ossicles, those middle ear bones, or to repair a ruptured eardrum, for example. Sign language is a main way that people with profound hearing loss from birth tend to communicate. Important to note that some deaf individuals do not perceive hearing loss as a condition that requires treatment. They view themselves as fully whole and as the hearing loss is something that doesn't need to be managed medically. Right? These folks are just as intelligent as anyone else. They just communicate in a way that's different from most of us. If you found this video useful, please like, subscribe, and share. You can subscribe to my monthly newsletter with board-style questions for genetics exams, and you can also buy me a coffee to show your support for the channel. Thank you.